Hi, everybody. This is the Mental Health and Violence Assessment lecture for your assessment class. Please make sure that you're participating in the Ed Puzzle pop-ups when you see them so that you can get attendance credit. The lesson objectives are the same as what you have in your lesson plans for each week. Number one, examine the relationship between mental health and other concepts and systems. Demonstrate common assessment procedures used to examine violent behavior, and demonstrate the nursing process, as we always do, in providing culturally competent and caring interventions across the lifespan for individuals with common alterations in mental health. We're going to start by talking about cognition rather than getting into mental health disorders first. There are alterations in cognition that impact a patient's health. So your Pearson book defines it as a complex set of mental activities through which individuals acquire, process, store, retrieve, and apply information. So when we have an alteration in cognitive status, it can impact our quality of life. For example, patients with Alzheimer's disease or dementia, whether it's the dementia or delirium is temporary, it certainly can impact a patient's health. Cognition is a function of the nervous system. Disturbances can be major, minor, permanent, reversible, chronic, or acute, and small disruptions can impact quality of life. So I want you to think about the ways in which an altered state of cognition can impact a patient's quality of life and their functioning. As I mentioned, alterations in cognition can be permanent, they can be temporary. So it's important that you understand the difference. Dementia is more a permanent diagnosis versus delirium. So dementia, it's going to be slow, subtle, and consistent. I had mentioned to other classes that my father has early onset dementia, and it manifested itself by him forgetting where he was going in his car. He does not have Alzheimer's disease, but he does have early onset dementia. It is subtle, slow, and consistent, and we do have to keep an eye on it. And it's not reversible. The motor function declines later, so you're going to see cognitive issues first before we see motor signs as far as the ability to walk, feed themselves, and so forth. Increasing difficulty in finding words for things, very common things like forgetting that a coffee mug is called a mug. You'll find people saying, I just can't think of the word for that, and it's something really simple and common. And it's a gradual worsening of the memory. Most of the time, the long-term memory is retained because that is stored in a different place in the brain, and you'll notice that short-term memory is impacted quicker. Whereas delirium is usually sudden and severe, usually temporary. You may see restlessness, tremors, slurred speech. The memory remains but may be limited. So one example of delirium is when somebody is intoxicated. And there can be other reasons that people have delirium. It can be disease related, medication related, but it is different than dementia. While the behaviors may mimic each other, the diagnoses are a little bit different and the causes are different. In either case, we are always primarily concerned with safety. So when you're doing an assessment on somebody with delirium or dementia, that is always going to be a key diagnosis. We're always going to do a risk for injury related to whatever you're concerned about. It may be suicide, it may be falls, it may be some other type of self-harm, even if it's not intentional. So safety is always going to be the primary concern when you're dealing with a patient with altered cognition. So for the assessment piece, you're going to use the mini mental status assessment. It's frequently used to screen for Alzheimer's disease, but also somebody with suspected dementia, it can be useful. So anytime you suspect a cognitive disruption, and you may have family members verbalizing their concern, you may have the patient, him or herself, saying things like, I was driving and I got lost, or I can't think of simple words, it would then be appropriate to conduct a mini mental status assessment. It's usually done on the elderly, but it can be done on somebody who's younger, depending on what the circumstances are. So this is a YouTube video just demonstrating the questions, how they may be asked. So pay attention to how they're asked so that you're able to conduct this assessment with a partner.
Hi, Rebecca. How you doing?
I'm good. How are you?
Pretty good. Can I ask you what hand you normally write with?
My right hand.
Your right hand? Would it be all right to ask you some questions about your memory?
I guess.
Okay, thank you.
Did you notice that when he started, he asked, is it okay if I ask you questions about your memory? So you want to ask the individual permission if that's okay that you're going to be asking them about their memory.
I'm going to ask you some questions and give you some problems to solve. Please try to answer them as best as you can. What year is this?
2015.
What season of the year is this?
Winter.
What is the date today?
January 20th.
What day of the week is this?
Tuesday.
What month is this?
January.
Can you tell me what country we are in?
United States.
Do you know what county we're in?
Newcastle.
Do you know what city we're in?
Newcastle.
Do you know the name or the address of this building?
Wilson Graduate Center. No, I know the name. 3 Reeds Way. 31 Reeds Way.
What floor of the building are we on?
First floor.
I am going to name 3 objects. After I've said them, I want you to repeat them back to me. Apple, table, penny.
Apple. Table. Penny.
Now, one thing I want to point out here is if she had gotten it wrong, you don't want to say wrong and tell them what it was. Okay, we're recording exactly what they're remembering. So even if they got it wrong, you can say thank you for the answer. Now, if they ask you if they got it wrong, it's okay to tell them, but you don't want to be pointing out and saying, nope, you were wrong with that. We're just simply collecting data based on their recall.
Remember what they are, because I'm going to ask you to name them again in a few minutes. Now I'm going to give you a word and ask you to spell it forwards and backwards. The word is world. First, can you spell it forwards?
WORLD.
Now, can you spell it backwards?
DLROW.
What were the 3 objects I asked you to remember earlier?
World? No. Apple? I can't remember.
What is this called?
This one.
If you don't happen to have a watch on, you can show them another common item like a cup or even a pen.
What is this called? I would like you to repeat a phrase after me. The phrase is, No ifs, ands, or buts.
No ifs, ands, or buts.
I want you to read the words on the page I'm going to hold up and then do what the words say.
Close your eyes.
Thank you. Mhm. Take this paper in your right hand. Fold the paper once with both hands. And put the paper down on your lap. On this piece of paper, write any complete sentence on that piece of paper for me. Thank you. Here's a drawing. Please copy the drawing on the same paper.
Sorry about that pop-up.
Thank you. That concludes this test. I want to thank you for your cooperation.
So the point of that video was to just demonstrate how you would be asking the questions. Make sure that you're asking it in a clear and concise way. And again, we're not saying to the patient, oh, good job, you got it right, or no, you didn't get it right, okay? So this is the mini mental status exam that if you choose a scenario where we're concerned about the mental status of someone, this is exactly the form that you're going to use. It's not a physical assessment, it is a subjective assessment. So you would put the patient's name and date, and these are the questions that he actually asked, or similar questions that he asked that patient. And what you do, for example, if you're the number one, there's a maximum score of 5. So you're going to ask what's the year, season, date, day of the week, and month. Those are 5 questions. So if they get one wrong, the score is a 4, and so on. Same thing here. Where are we now? What state are we in? County, town or city, hospital, floor. Whatever their score is, whichever number they got right, you put that there, okay? And so forth. When you get down here, you're going to give them a piece of paper and show them this image and ask them to copy it. So I will provide the paper for you, and then you'll have them draw it, and all 10 angles have to be present in order for you to interpret it. I'm not asking you to memorize the interpretation. You will have the scoring instructions in front of you. I'm looking to make sure that you are able to sit and talk with the patient, that you're talking slowly, and that you're recording their answers correctly. So this is all the information on how the results would be scored, and based on that, this is an interpretation. So if they have a score of less than 24, that is abnormal. Again, we are not diagnosing. Okay, we're not diagnosing. This is a screening tool. We would report the findings to a physician, and then they would make the appropriate referral for further assessment. So keep that in mind. So if we're looking at a range, less than 21 would be an increased odds of dementia. Greater than 25 is decreased odds. If we're looking at the educational level, A score of 21 would not be normal for somebody with an 8th grade education, so you have to consider those things as well. And then we're also looking at severity. Okay, there's a range here. 24 to 30 would be no cognitive impairment. Severity 18 to 23 would be mild. Severity 0 to 17 would be severe. So I want you to focus on the severity section when you're scoring your partner, should you select this as your assessment. Make sure, I know it's easy because you have the paper in front of you. It seems easy, but make sure that you practice this with somebody, because you can't say to me during assessment time, how am I going to go about doing this section? I'm telling you now. So you need to practice it and make sure that you know how to answer the questions or ask the questions. So we're moving from cognition to mood and affect. Mood would be an internal subjective state by telling you I feel sad, whereas affect is objective. It's an emotional response to mood. For example, crying. So if you're describing somebody's affect as flat, it means that they've got no expression and you can't really tell how they're feeling. So mood is going to be subjective, affect is going to be objective. Continuing on with mood and affect. Emotions, mood, and affect become dysfunctional when they occur in inappropriate circumstances. So if you have somebody who just received good news and they're hysterically crying beyond the emotional tears, that can be inappropriate. Or somebody just finds out that a loved one has died and they laugh uncontrollably. So it's out of proportion to the stimulus. Somebody throws a tantrum because they didn't get their burger done correctly at a restaurant and they freak out. Okay, so that's out of proportion to a stimulus. And they shift dramatically out of proportion to certain events. So you can look at the table for more information on that in your Pearson book, page 1776, 28, 1. Everybody has alterations in mood, no doubt, but they become disorders when the mood and the affect rise to the level of impaired functioning. Depressive disorders are when somebody is severely depressed and it's impacting their quality of life. It may be feelings of sadness and hopelessness, discouragement, and anhedonia. If you don't know what anhedonia is, please look that up. But that would many times be somebody describing this extreme feeling of sadness and hopelessness when there's no direct reason. People can suffer from depressive disorders when there are reasons, but it's more often diagnosed as a depressive disorder when in the absence of a stimulus. You would expect somebody to be depressed if they received a diagnosis, where they're going to die, or when a loved one has died. So depressive disorder is more likely to be in the absence of a direct stimulus. Bipolar disorders is where there is depression that alternates with mania, which is extreme excitement, or hypomania, which is not quite as extreme, but it's still where the mood lifts and then the person sinks into depression. And bipolar disorders are much more common than we realize. There's many people among us with bipolar disorder, but it can really impact a person's quality of life. And then there's anxious distress, which would be manifested by restlessness, inability to concentrate, fear, and worry. So some anxiety is expected, people in nursing school, but when it gets to the point where it's impairing quality of life and the ability to succeed, then it needs to be addressed. So nurses should understand mood disorders and the fact that they occur in all clinical settings, not in just behavioral health. For mood disorders, the number one concern for nurses or any healthcare provider is staying safe and unharmed. So suicide prevention is number one, and we want them to maintain their physical health. So anytime somebody talks about wanting to kill themselves, having a plan, then that takes number one priority, and we would then be making sure that we're observing them on a one-on-one situation. We take that very, very seriously. So safety is number one. Suicidal ideation is where they're coming up with an actual plan on how they're going to kill themselves. So that any remark about somebody killing themselves must be taken very, very seriously. And that is considered top priority as much as somebody complaining of chest pain or shortness of breath. We put that as number one and we take it seriously. Even if you suspect it's not true, we treat it as though it is. So you can look at the table on 1777 and 1778. And I want you to think also about potential nursing diagnoses if somebody is verbalizing the fact that they want to kill themselves. A tool that we can use to assess depression is called the CESD-R, and that stands for the Center for Epidemiological Studies Depression Scale, and the R means it has been revised. This scale is something that if somebody presents complaining of a depressed mood, this is likely not going to be used for severe depression, somebody who's obviously suicidal, but somebody that is complaining of a depressed mood, we can have them actually complete the scale. And it's an online tool that you can pull up, and it goes right through the questions where it says start, and then it asks the individual, my appetite was poor, and it gives you an idea how much their mood disorder or their feelings are impacting the quality of life. So somebody's appetite was poor every day, and it goes to next. I couldn't shake off the blues 1 or 2 days. Maybe they're not severely depressed. I had trouble keeping my mind on what I was doing nearly every day. I felt depressed, let's say 3 to 4 days last week. My sleep was restless nearly every day for 2 weeks. I felt sad, let's say nearly every day for 2 weeks. And you can see some of these questions are asked in a different way. I couldn't get going every day. Nothing made me happy 5 to 7 days last week. I felt like a bad person 5 to 7 days last week. I lost interest in my usual activities, let's say 5 to 7 days. I slept much more than usual, nearly every day for 2 weeks. I felt like I was moving too slowly. I felt fidgety. I wished I were dead. I wanted to hurt myself. I was tired all the time. I didn't like myself. I lost a lot of weight, not at all. I had a lot of trouble getting to sleep. So you can see they're reworded. Couldn't focus on important things. And then it gives them a score, okay? So it lets them know exactly how high their risk is for a depressed mood. Okay, so based on the answers, depression is an important problem for you. We recommend you make an appointment. So again, that is a screening tool, and at that point, we would email to the physician or print it out, and then an appropriate referral could be made. For the assessment test, the first one, I'm not going to have you do a CESD-R, but I do want you to be aware as future nurses that this tool does exist, and it's easy to access on the internet, and we can ask those specific questions and find out if there is an indicator that the person has more of a depression that needs to be addressed. Suicidal ideation refers to the fact that somebody may actually have a plan on how they want to kill themselves. So we want to be direct but respectful. Are you considering suicide? If they say yes, do you have a plan for killing yourself, and what is the plan? We want to avoid phrases like hurting yourself because we want to be direct, okay? Because there are lots of different ways that people hurt themselves. For example, cutting as an emotional release does not necessarily mean that somebody wants to kill themselves. So we want to actually have an idea. Are you planning on killing yourself? And if so, what is the plan? So the goal is patient safety. If somebody is suicidal, talks about it at all, we take it very, very seriously, and we need to have supervision, have a healthcare professional assess the person, and we take it as seriously as chest pain or somebody who is complaining of shortness of breath. So make sure that you understand how important that is. The substance abuse assessment needs to be non-judgmental. We all have our own ideas about how somebody should, how we want to live our own lives, but you want to make sure that you are not conveying an air of judgment towards somebody else, and that takes practice. So if there's somebody that you suspect is abusing a substance, we do not want to be judgmental. You would ask, how much alcohol do you drink? Versus, you don't drink too much, do you? Because that sounds very judgmental. Another way to approach it, if you suspect that somebody has an alcohol abuse problem, if they're having tremors, serious signs of withdrawal, asking a question such as, when you drink alcohol, do the tremors go away? Okay, because that's going to give us an indicator as to how addicted the person is. So make sure you're asking non-judgmental questions. Tests to help the nurse determine the degree of severity would be, there's two different tests. And again, I'm not going to have you do these on the assessment, but I want you to be aware of them. There's the Michigan Alcohol Screening Test, or the MASS test, which you can find on page 1540. And then there's also the CAGE questionnaire, which is also on page 1540. So you can look those up in your book and get an idea of what questions we're asking patients when we suspect that there is substance abuse. Again, I'm not going to ask you to perform those, but it is a questionnaire that's important, and I do want you to look at some of the questions on those questionnaires. Moving on to violence. Pearson defines violence as excessive force against other individuals or oneself, often resulting in physical or psychological injuries or death. And it's important to understand that abuse is all about control. As I just said in the previous slide, the main thing about any type of abuse is control. So when we are assessing somebody that we suspect is being abused, one of the most difficult things to do is to get them alone so that we can actually ask the questions. You are not going to say in front of somebody's spouse, is he abusing you? Because that's a very dangerous thing to do for the victim, who is not going to admit it anyway. And then you alert the potential perpetrator that you're suspicious. So we don't want to do that. It's very difficult to get somebody alone, and nurses have to be tricky and creative trying to get the suspected victim alone. So types of abuse are physical. You can see in the top picture. There's obvious signs of abuse and less obvious signs, emotional abuse, sexual abuse. Again, we are mandated reporters. So if you ever suspect abuse, for a vulnerable population, then it has to be reported. It's a little bit more difficult in populations, domestic abuse, because there's a choice. And if the individual who is being abused does not want it reported to police or does not want to seek protection, all we can do is provide the information, and they have to agree to it and take it from there. Now, the elderly, children, somebody who has intellectual disabilities, they are considered a vulnerable population, and then at that point we have to report the abuse. You will get into more about assessment of abuse and how to handle these things when you get into later classes. There's actually a sim that we take you through, but for this class you have to be aware of the different kinds of abuse and some things that you might see. Vulnerable populations, as I mentioned, would be age-related, the very young and the very old. Physiological development, people who are ill or disabled are vulnerable populations where you would have to report suspected abuse. Psychologically would be, severely psychologically impaired would be considered a vulnerable population. Cultural considerations. Some cultures condone physical and emotional punishments. They don't say abuse here. So we have to take that into consideration, although People of different cultures have to still follow the laws of where they are. So there may be some physical abuse that's appropriate. Sorry, I had to stop because I had to sneeze. I was talking about cultural. The cultures condone physical and emotional punishment sometimes, but they have to follow the law. So if you suspect abuse and it's somebody from a different culture that it's acceptable where they are, they still are responsible for following the laws here. Socioeconomic factors, poverty is an influence and makes somebody more likely to be abused. Doesn't mean they will be, they're just more likely. Substance abuse and those people who keep firearms in the home. Make sure that you take a few minutes and look at page 1972 and 1973 for clinical manifestations and therapies for abuse, because it is important that you're able to identify when you suspect that there is abuse. And it's not always going to be overt. There are different things like somebody isn't showing up for appointments on time consistently that may warrant some investigation. The perpetrator who potentially is abusing the person never leaves them alone, doesn't allow them to answer for themselves. So make sure you're reading that section in the book so that you understand what to look for. There is an abuse assessment screening tool that can be used. This can be difficult because you have to be able to get the victim that you suspect is being abused by him or herself, and that can be hard, but that is key, trying to get the person by themselves so that you can actually assess it. So this is just a quick screening tool. Have you ever been emotionally and physically abused? And you do know, if those of you who work in healthcare or when you actually go to access healthcare, that they automatically ask that question, have you ever been a victim of abuse? So we are actively screening, and it goes down through the questions to let you know if this is a potential issue and if we need to try to intervene. Again, if the individual is not part of a vulnerable population, all you can do is let them know what help is available, and in the end it's their choice if they want to act on it. I just want to clarify also that I'm not going to make you ask these questions for the assessment test, but I want you to be aware that the screening tool does exist. So this concludes the presentation. This is just a recap of the lesson objectives. Make sure that you are looking at that mini mental status screening tool that you will be responsible for being able to use. So make sure that you're looking over that and that you know exactly how to ask the questions, because again, during the assessment, I'm going to expect you to know how to use it. So when you practice it, the questions that come up should be asked before you're actually in an assessment situation.